Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have our presenters in conference. Please be aware that each of your lines is in a listen-only mode. Questions will be facilitated within the web presentation today. If you have a question, please submit your question anytime by using the Q&A pod located to the left of your webinar screen. You may also download a copy of today's presentation from the resources pod located below the Q&A pod. It is now my pleasure to introduce Monique Showalter of AHA Solutions. Monique, you may begin.
Thank you so much, Stephanie, and welcome everyone to today's webinar entitled Nurses Lead Transformative Telehealth Initiative, featuring Lehigh Valley Health Networks, who will highlight the essential factors for success. My name is Monique Showalter, and I'm the moderator for today's webinar. Telehealth doesn't just offer benefits to patients in the form of streamlined care and improved outcomes. It can also boost hospitals' bottom lines by avoiding unnecessary costs. But how can you ensure development and implementation of the most effective telehealth initiative? During today's webinar, Lehigh Valley Health Network will share their implementation of telehealth through a nurse-led initiative, outline the innovations within the LVHN Center for Connected Care and Innovation, and detail the essential success factors of telemedicine design, implementation, and evaluation. You'll hear how this organization created an organizational structure that supports and facilitates their telehealth initiatives, positioned their telehealth programs as clinical in nature, and truly very successfully defined the roles and responsibilities of the care team. Additionally, they'll share how critical considerations in developing and implementing a telehealth initiative is important, including soliciting and incorporating nurses' staff perspectives. You'll learn how this organization's telehealth program contributes to cost avoidance, improved population health, and enhanced patient outcomes. Today's program also includes a Q&A session. If you have a question at any time, we welcome your typing it in the Q&A section on your screen. At the conclusion of the webinar, you'll see a brief evaluation on your screen. We invite you to take a minute to complete the evaluation so we can continue to bring you educational programming in the future. The evaluation will also be included in the thank you email you'll receive at the close of the presentation. This program has been produced by AHA Solutions, a division of Health Forum, the strategic business enterprise of the American Hospital Association. AHA Solutions is focused on improving the performance of our nation's hospitals. We co-founded the National Healthcare Career Network and the Health Career Center to address critical staffing issues and connect healthcare employers with highly qualified candidates. We actively seek to understand pressing operational issues facing our hospitals. Then we research high-value products and services that address those critical challenges and award an exclusive AHA endorsement. Educational programs such as today's webinar are designed to discuss the challenges facing healthcare organizations and the solutions available to them. This educational event has been developed by AHA Solutions together with AMC Health. Remote patient monitoring and engagement solutions from AMC Health have earned the exclusive endorsement of the American Hospital Association. We thank AMC Health for their willingness to share their expertise. So let's talk about today's presenter. Sharon Cromer is one of 3 clinical nurse coordinators in the Lehigh Valley Health Network Center for Connected Care and Innovations. She's charged with the responsibility to organize, direct, develop, and implement telehealth programs within and external to the health network. Among others, Sharon coordinated development and oversees the ongoing operations for remote patient monitoring, tele-infectious disease, baby cam, virtual observation, and teleneuro. Sharon is certified as a telehealth coordinator and has presented widely on the subject throughout the United States. And in fact, she recently published an article on telehealth in the Journal of Nursing Administration. We're delighted that Sharon has made time to share her experiences with us today. With that, I'll pass the podium over to Sharon to share Lehigh Valley's experiences and success with telemedicine. Sharon, welcome. The podium is yours.
Thank you, Monique. And I'd like to thank the American Hospital Association as well as AMC Health for giving me this opportunity to share Lehigh Valley Health Network's telehealth journey with you today. By starting with the objectives for today's presentation, it is to distinguish components vital in the design, implementation, and evaluation of a successful remote patient monitoring program, and summarize a successful structural model which used RPM technology to achieve a transformative, new, safe, quality, and affordable care delivery system. So to give you an idea of who Lehigh Valley Health Network is, we're located in eastern Pennsylvania. We have 5 campuses, over 140 physician practices, and 11 express care locations with over 13,000 employees. We are a level 1 trauma center, a regional burn center, and have a children's hospital that includes a level 2 pediatric trauma center and a level 3 NICU. To point out a few of our milestones at Lehigh Valley, we're a comprehensive stroke center. We're on the list of the most wired hospitals, as well as one of the U.S. News and World Report's America's Best Hospitals for 20 consecutive years. We have also obtained magnet status designation for the 4th time. While on the subject of magnet, in 2013, we were honored to receive the Magnet Recognition Program 2013 Magnet Prize for innovations associated with our telehealth programs. Today, due to access issues and ever-increasing costs for care, many hospitals are at their tipping point for explosive opportunities and growth in telehealth. While remote patient monitoring was our first telehealth program in 2003, at Lehigh Valley Hospital, our tipping point began in 2004 with our advanced ICU. In order to support the development of additional services, an experienced telehealth professional was recruited as a vice president to create and lead our new telehealth department at Lehigh Valley. In designing the new telehealth department and service, the VP identified 3 major components necessary for success. There's administrative, clinical, and then technology informatics. Although IT plays a huge role in the development of telehealth programs, the expertise needed varies depending on the technologies being used for each program. Therefore, a decision was made to consult with our IT colleagues as needed. Joe Tracy, the VP of Telehealth Service, firmly believes that these programs are clinical in nature, reinforced by his statement, "It is not about the technology, but rather about the clinicians using the technology to care for our patients." To support this commitment, his first hire for the department was a nurse, followed by 2 additional nurses. All of us have titles as clinical coordinators. Currently, there are 17 different telehealth programs here at Lehigh Valley, and this number continues to grow. Last year, over 31,000 patient encounters occurred using some form of telehealth. Our remote patient monitoring program was started within home care. A few years ago, a decision was made to pull the program out of home care in order to monitor a large population of patients. Since our outpatient practices fall under a different company from our remote monitoring department, contracts needed to be developed between the 2 companies, and a payment for service needed to be provided at a fair market value, which is part of this agreement. Our nurses that work in the remote patient monitoring department either previously worked in home care itself or currently work part-time in home care and do a job share. We feel that the nurses monitoring patients in the home need to understand the situations and challenges that may occur in that home setting. In developing the program, we also felt strong about the department functioning 365 days a year. Traditionally, there are less resources on weekends and holidays, and access to care can be little more difficult to navigate. So we feel it's important to have these experienced nurses available to assist our patients on the weekends and holidays. We tend to promote our telehealth programs by stating that it is so much better to replace the traditional conversational curbside consult with a visualization of the patient or patient data to improve the care that we're providing. Therefore, instead of just listening to me talk about our program, here's a video that features how Lehigh Valley has improved the care we provide to our patients.
It was almost exactly a week. I think I left the hospital on a Monday, and that Saturday, I got up and I just felt tired. You know, I didn't feel like things were right.
After Mr. Patterson had tested, I received his results and I noticed his vital signs were not within his normal testing parameters. I called Mr. Patterson and had him do another retest of his vital signs just to confirm that it was accurate.
So I did it again, and right away they called and said somebody will be to see you, and I think within the hour.
I definitely knew after that second test something was definitely wrong. They were not typical for him. They were abnormal. I called the home health department and had them send a home health nurse to evaluate his situation.
There was a nurse at the door and did all my vitals manually, and then she got on the phone and talked to someone at the hospital and set everything up. It's the trauma of the heart surgery will trigger arrhythmia every now and then.
Because we were able to pick up the irregular heartbeat while he was at home, we were able to get him back to the hospital to avoid further complications such as a stroke, and to let us give him the proper treatment to restore him back to a normal, healthy heart rhythm.
So I think this system really helped and supported him, and kept him from going into a stroke. Hi, Andrea. I'm Angie.
Nice to meet you.
Nice to meet you. Makes me wild.
I'm Ed.
Hello. It's nice to meet you
It's
finally.
nice to meet you, and thank you so much, all of you people, for what you've done.
You're a lifesaver. You really are, and and just so calm and in a very stressful situation. I think from my perspective as a caretaker, as far as having the monitor, I think it's an important piece to give you, as a caretaker, peace of mind, as you know that you have a connection, a quick connection to somebody that is keeping track of, how your spouse or child or whoever is doing. It was life and death. And you realize that when you go to the emergency room and they have you there immediately after seeing the readings.
The technology made a huge difference.
Could have saved his life.
Sharon, the video has ended. Feel free to take over your presentation again.
Thank you. Prior to making the changes within our program, a decision was made to look at what technology was available for remote patient monitoring. After 2 years of evaluating a variety of applications, we made a decision to move forward with AMC Health. As an organization, we like to partner with companies that are innovative and willing to work with us to meet the needs of each individual program. Another deciding factor included the need to have software capabilities to easily access metrics. Since there is no true form of reimbursement for remote patient monitoring, we need to have the ability to justify the costs with showing improved patient outcomes. We are currently monitoring patients seen by home care, community care teams, and our HIV clinic. AMC Health provides the support for conducting the equipment logistics, the patient instructions, and support. It is very important that Lehigh Valley maintains that direct relationship with our patients for the remote patient monitoring program. Therefore, our staff installs the equipment and performs the daily monitoring of the patients in order to assist with the patient engagement and compliance. As a direct result of our caring and dedicated remote patient monitoring staff, I am so proud to point out that they have maintained a 98% compliance rate. The nurses are excellent with engaging patients and ensuring they are performing their daily vital signs. With the expansion of our program beyond home care patients, we're hoping to increase the average length of stay of our patients that are on the remote monitoring. With our remote monitoring program in its own department, we no longer have to pull the equipment out of the home at that end of that home care encounter. As we all have learned, everyone is different. While one person can change a behavior in 21 days, it may take another person much longer. Therefore, we are now able to monitor the patients for a longer period of time to ensure they're comfortable with monitoring their own health and do not need the daily oversight of a healthcare provider. Many of our patients have asked to keep the equipment longer because they feel so much better knowing somebody is keeping an eye on them. When talking about outcomes and implications, while it improves access and the quality of care that we're providing and at the same time can reduce costs, the bottom line for us is that it's the right thing to do for our patients. When you're talking about the key issues impacting telehealth, in this slide, the size of the bubble is how big the issue is for telehealth. So the green dots show that you're good to go. They've been addressed. Most of the vendors are well aware of it, and they're able to address those issues. The yellow, you want to approach with caution, and the pink, you really need to stop and take a good look prior to proceeding with your program. The mixture of colors represents somewhere in between. Important things to think about when you're developing your programs. I don't think I need to explain the purpose of ACOs and Medicare shared savings programs, but the care of patients can be provided through the use of telehealth technologies. For your reference, the Federation of State Medical Boards and the American Medical Association have come out with safe telemedicine guidelines. According to the Federation of State Medical Boards, they basically state telemedicine is not audio only, telephone conversation, email, instant messaging conversation, or fax. It typically involves the application of secure video conferencing or store and forward technology to provide or support healthcare delivery by replicating the interaction of a traditional encounter in person between a provider and a patient. The AMA recommends that a face-to-face examination occurs to establish the patient-physician relationship, and that encounter can be in person or virtually through real-time audio-video. I would also like to make you aware that some of the non-traditional healthcare providers are now moving into the arena using telehealth, such as pharmacies and insurance companies. For considerations beyond the legal and regulatory issues, ensure you align your programs with the goals of your organization and the needs of your community. When looking at expanding your telehealth programs, take a look at your current programs and see how you can morph them to meet the needs of another department. A good example from us is our teleburn program. Our burn surgeons receive 2 digital photos of a burn while having a telephone conversation with a referring provider. This then led to our telewound program with a local nursing home, and in turn morphed into our inpatient telewound program. So now our clinical nurses take 2 digital photos of a wound and attach them to a consult to the wound nurse in our EMR. This gives the wound nurse the ability to triage the patients more appropriately. Now they know who they need to see in person and who can they give a recommendation to the clinical nurse over the phone. So it's saving them on time and actually increasing their ability to be able to see the patients who really need them at the bedside. When it comes to funding a telehealth program, sometimes you need to be creative when looking for a funding source. We're always looking to see if we can apply for grants or use philanthropic dollars to start a new program. Lehigh Valley and none of our partnering hospitals are considered rural by CMS guidelines. So we will contract with the smaller hospitals to offer them our specialty services using telehealth. Since we don't receive that reimbursement through the traditional payers, we charge that partnering site for the service that's provided. In the end, the decision to move forward with a program may come down to how are we improving patient care and losing less money as an organization. In November of 2015, the Air Products Center for Connected Care and Innovation at Lehigh Valley Health Network was developed as a result of a generous donation by the Air Products Foundation in honor of their 75th anniversary. This gift will be used to develop and launch innovative ways to improve and deliver health care at Lehigh Valley Health Network. And of course, telehealth is a large part of innovation. So I would like to come to an end with this presentation by pointing out the importance of seeing the big picture when using telehealth for the care of your patients. So looking at this picture, it was given to us by Dr. Shosher, who is a dermatologist at East Carolina University, and he does provide services through telehealth. And if you look at the picture, it has irregular edges and irregular colors. It looks like it could be a melanoma. So Dr. Shosher, when he saw it, he said, I would really like to see a little bit more of this patient to get a better look at what's going on. So, as you can see, by the bigger picture, it tells a much different story. So the one thing I want to remind you, when using telehealth, you always want to make sure you're looking at the entire patient. Don't focus in on one small area. You want to do the same thing as if you were walking into that exam room or into that patient room and you were assessing them. You want to look at the whole person. So I would like to say our reference for this presentation was based on the article, as Monique stated, in Jonah Magazine of December of 2015. And then there's my contact information. And if you see the link that says lvhn.org/telehealth, you can go onto that website and see more of our programs that we use telehealth for and get a better picture of what we do with our telehealth services here at Lehigh Valley.
Thank you, Sharon. That was truly an outstanding presentation, and we thank you for sharing so many of your insights and experiences as to how Lehigh Valley was able to develop and implement such a successful and remote patient monitoring program across so many of your groups. So let's move on to the Q&A section of today's program. As a reminder, if you'd like to ask a question, feel free to type it in the Q&A portion of your screen. We have a number of pre-submitted questions, so we're not for lack of questions by any means. Sharon, the first question is kind of a strategic question that relates to, other than funding and full support by senior leadership management, what do you think the greatest challenge was to launching a formal telemedicine or telehealth program that might be used at multiple locations by several hundred providers?
The key factor there is having providers, whether it be physicians or nurses, who are truly on board and want to be that bus driver and that champion for the program. Because if you don't have folks buying into it that are going to be using it on a daily basis, you might as well not even spend the money or the time trying to implement that program. You really need to find somebody who sees the benefit and is going to want to drive that program and promote it at within their own department.
Great. Another question that came up, again, at kind of a strategic level, what were the key business drivers that initiated your telehealth efforts and initiatives?
Truly improving patient outcomes. Ultimately, we hope to decrease costs, but our true focus is improving our patient outcomes. And again, the example of our advanced ICU, and that's where our tipping point was and says, wow, this is really doing a fantastic job. We need to see how we can use telehealth in other departments. Because we did publish a study for our advanced ICU, and what we found, we looked at 950 patients before we used the advanced ICU and then 950 patients after. And our mean ICU length of stay went from 4.1 days to 3.8. Our ventilator use rate went from 36.1% to 31.5%. They found that the nurses at the bedside gained 90 minutes more in care times per 12-hour shift. And then they also showed a 30% relative reduction in mortality using the Apache calculations. We had an improved time of 60 minutes for the turnaround from the antibiotic order to administration. So what they really found is that for every patient we're treating in our ICU, we're saving one additional life using our advanced ICU. With our advanced ICU, it is an added layer of care. So it's not taking anything away from our bedside. It's not truly decreasing costs for operations, but we're seeing that improved outcomes for our patients within our own organization.
Another interesting question, Sharon, and that came up about what was the economic incentive that, for this level of engagement? Was there an economic incentive involved?
We do hope overall, and as we're moving into that, you know, the ACOs and the decreased payments, that by using telehealth, we'll lose less as an organization, and we'll be able to decrease those 30-day readmissions and not receive the penalties that we have in the past for, you know, for the care.
Okay, another question. Do you bill for nurse-led care? And also related to that, how do you overcome the challenges as it pertains to reimbursement? I know you touched on that in the presentation. Can you speak to that once again?
Sure. Currently in our population health department, we are not billing for the comprehensive care management of a patient. That is a free service that we offer to our patients, but not saying that it's not something we're looking into. We are trying to move towards billing for services that in the past we have not been able to bill for. And again, you know, when we are working with smaller community hospitals and allowing them to keep patients that they haven't been able to care for in the past, we do charge them it's a small nominal fee, but we do charge them for that service.
Great. Another question related a little bit to the technology aspect. Do any of your telehealth services include video, or is it primarily through phone?
It all depends on the program of what we're doing for the video. So all of our, like our telestroke, our tele-ID, our advanced ICU, programs such as that are using live audio video. But then there's other things such as our burn that uses just, our telewound that uses just still photos, digital photos. And then our remote patient monitoring, currently it's the wireless devices and then the IVRs through the phone that are used with that program. So it all depends on the program, on what technologies we use.
All righty. Another question, and this relates primarily to the project elements. How intimately involved was IT in enabling and empowering your desired optimal processes as clinicians?
We rely on our IT department heavily. The reason we don't have somebody specifically from that with an IT focus in our department is because there's so many different aspects within the IT department or specializations. So it all depends on the technologies that we're using, on who we pull in. So if we need somebody from network or firewalls or from programming, you know, somebody within our electronic medical record resources, depending on the project and what the needs are, that's when we pull the different specialists in from IT. But they are intimately involved in all of our projects.
All right. Another question relates to how the telehealth programs are affected by HIPAA regulations. How did you address that through the various programs?
We always ensure that everything is encrypted. And of course, we always bring our security guys in from IS just to make sure from their perspective, everything, you know, is okay. We have had a few products that we brought in that they were not happy with the level of security from a HIPAA perspective, and the vendor had to make changes before we would move forward with their product. So our security within our IT department scrutinizes that very carefully, for every program that we implement.
Great. Another question, other than the diagnosis, how else do you screen your patients for appropriateness within the telehealth programs?
Usually it's the provider who makes the decision that this patient is appropriate for telehealth. And I think that's pretty much throughout all programs. Because within our remote patient monitoring, it's the provider who says, oh, this patient will really benefit, and then they send a referral to our department to enroll the patient. Now, the patient still has the ability to say, no, I do not want to participate in this, or we do enroll them and we find that they're not compliant and they're not following the instructions of what needs to be done, and it's a wasted resource where we could be using that equipment on somebody else. So then we will pull them out of the program. But a lot of it is truly determined by that provider who refers them into one of the telehealth programs.
Great. Another question here. They're really flying in. When do you first connect with the patient after hospitalization, and how much time is spent with the patient while they are on your service? I assume that's very dependent on the type of program, whether it's ED or maternity ward or what, but generally, is there a rule of thumb, or is it very unique to the specific application of the program?
Yeah, it all depends on when the provider is referring them to us. They may refer them to us right on discharge from the hospital, or they may not feel they need anything, but then the patient's having issues a couple days after they go home, and then they'll refer them to us. So that varies on when they enter the program, depending on the provider and the patient. But the time that we spend with them, we do have a technician who goes out into the home and sets up the equipment and instructs them how to use the equipment until they feel comfortable and they know they can actually operate the devices. Not that the devices are really hard to use, but they want to ensure they're comfortable with them in the home. And then our nurses, I don't know about on a daily basis, but if patients for some reason are showing a trend that they may be declining, they'll be right on the phone giving them a call and checking in with them to see what's actually happening. So they talk to the patients. They get to know them really well. They do. And if you saw in the video with Mr. Patterson, they could become very close to their patients in the remote monitoring program.
That being said, I'm curious what you feel is the greatest area of value for your remote patient monitoring program.
Oh, I don't know if there's the most value. We just see that there's a lot of people out there who need a little bit more of support than others when they're being diagnosed with either a new condition or their condition has worsened. And by using the remote patient monitoring, they can be given that support by nurses on a daily basis if needed. And we use it for your CHF patients and your hypertension and your post-MIs. So I don't know if there's truly one group that benefits more than another. That I can't say.
All right. And follow up to that, what clinical or population health needs do you plan to address in future remote patient monitoring programs? Have you decided on the focus area?
New programs that we're going to be starting is maternal fetal medicine wants to start monitoring their gestational diabetics. So again, that's pre delivery of the babies. So that's something we're looking at. And again, we're slowly, now that we're able to go outside of that home care population and see patients that are not necessarily with going home from the hospital and home care, we're able to now expand it out to a much broader population that we have in the past. Because another question that comes up is, the patient hasn't been in the hospital yet, but they were just diagnosed with CHF. Can we put them on a monitor and have them monitored to prevent them from being admitted to the hospital? So those are the things that we're really looking at promoting now. How can we do this more of a preventative measure and not as they were in the hospital now, how do we keep them out?
Great. Another question that came up, are you seeing a decrease in the number of patients in the clinics as a result of the remote patient monitoring program?
I don't know if there's an actual decrease in visits, because this is not to take away from what they were receiving in the past. It's just meant to be an added layer of care. Sometimes they're actually coming in more because now we're picking up something sooner and saying, oh no, you really need to have a doc look at you right now, just like with the video with Mr. Patterson. So it's looking at it from a perspective of we're now catching things at the right time and providing the right care to those patients. Instead of them letting it go for a couple days and say, well, I haven't felt good for a week now, it's getting them the care sooner that they truly need.
Great. Another question, and thank you, Sharon, for fielding. I feel like I'm an interrogator here, but there's so many questions that are coming in that are valuable. One actually speaks apparently to the respect people have for your accomplishments there. Did you develop an operational policy or a procedure manual for your users to guide their use of telehealth and telemedicine activities? And if so, would you be willing to share some portions of it?
Sure, yes. Because in Pennsylvania, the Department of Health feels that telehealth is a service, not just a tool. So before we implement any type of telehealth program, we do need to have approval by the DOH. Therefore, we need to have policies and procedures for each one of our different services. So yes, we do have operational and administrative policies for the different services we offer.
And would you be willing to share that on a limited basis to those of our listeners that might have interest?
Sure. If anybody, my contact information is in the presentation. They're more than welcome to contact, and we're willing to share that information, yes.
All right. Well, I think that we've addressed most of the questions that had come in throughout the presentation. So with that, I think I will bring our presentation to a close. And first of all, I really want to thank Sharon and for sharing your expertise and experiences throughout the webcast. And finally, a very sincere thank you to you, our participants. Program like today's webinar would certainly not be possible without your participation and inquiries and feedback. As I mentioned earlier, at the conclusion of the webinar, you'll see a brief evaluation on your screen. We encourage you to take a minute to complete the evaluation so we can continue to bring you educational programming in the future. We also wanted to make sure you're aware that you'll be receiving an opportunity to download the presentation through a PDF, and also we'll be sharing with you a replay link so you can forward it on to others in your organization. We also wanted to make sure you know that we have additional resources from the AHA, including the Health Career Center and to help you identify new resources and top talent. We also offer ongoing webinars, which are seen on screen now. So please visit us and make sure you capitalize on all the resources the AHA is offering to you. Sharon Cromer, I will thank you from the bottom of the AHA heart for all the lessons learned and experiences that you shared. As I mentioned, you'll receive the brief evaluation. We'll also be sending each of you a recording and a thank you email. With that, this is Monique Showalter with AHA Solutions. Take care and have a great afternoon.
Thank you, Monique.
Thank you, Sharon.
Thank you, ladies and gentlemen. This concludes today's conference. You may now disconnect.